Hi, everyone. I'm here with Dr. B, Dr. Berlin. How are you?
I'm doing great. Thank you. And thank you so much for having me.
Amazing. I'm so happy that we're talking tonight. And I hope you guys can see us well enough. My lighting is not very good, but Dr. Berlin is a very, very busy man. So we're sitting here at 8 o'clock at night doing this, and I'm so grateful. Um, so Dr. Elliot Berlin is a very beloved and award-winning prenatal chiropractor, childbirth educator, and labor doula who lives and works in Los Angeles. And that's how I got so lucky to have you be my prenatal chiropractor in both pregnancies with both
Hmm.
Maya and Maxwell. So we go way back.
We sure do.
And we had a pretty special experience actually with my pregnancy with Maxwell. And that's what we're going to talk about today. There are so many things I want to talk to you about, by the way, but we have we're going to narrow it down to one very special thing for tonight, and that is the disappearing art of vaginal breech births. So just real quick before we dive into it, because I think it's better to hear it from you than to hear it from me. What is breech? What does it mean when a baby is breech?
So normally at the end of pregnancy, babies settle into a head down position. About 96 to 97% of them end up in a head down position, which is the safest, easiest way for them to come through vaginally. Babies that are not in that position are either in a breech presentation or transverse. So essentially those two collectively mean something else is head down or nothing, something else is down by the cervix or nothing is down. The baby is just not even close to the cervix. And there are different kinds. They could be with their bottom down and their legs straight up towards their head like they're doing a pike dive. That one's called Frank breech. They could be bottom down with their legs coming down and sort of like they're doing a cannonball or cross leg cannonball into the pool. That's a complete breech. They could have a foot down there, just one foot, which would be a single footling breech. They have both feet down, or they can be just lying across, sideways, and that's transverse.
Right. So what happened when I was pregnant with Maxwell was that I think it was week 33 that we found out that he was breech. And I think he had his little butt down and feet up. And is it true that around week 34, they kind of want them to flip and be head down?
Yeah, I mean, they don't have to flip that early, but most of them do. So if yours hasn't, we start to wonder, why is your baby not flipping yet? Why is your baby not
Right.
turning head down?
Right.
So there's still some time. A lot of doctors start to check at 32, 33 weeks, see where the baby is. And if the baby's not head down yet, that's not really a panicky moment, but it's time to start thinking about the options. Like, are there things that we could do to naturally or medically encourage this baby to get head down before it's too late?
Right. And I think that's what happened with Maxwell because he did not want to turn. So we went to week 34, week 35. He did not flip. And I learned a lot during that time that I had never heard about before and never had to worry about before. Number one was that if he was going to stay breech, that I could not have my home birth with my midwife as I had planned because midwives are not allowed to deliver breech babies
In the state of California.
in the state of California. And I also learned that almost no doctors want to attend a vaginal breech birth at the hospital. So I don't know how much that has changed, but at that time, Maxwell is now 2.5, so this was almost 3 years ago, was that there were only 3 doctors in all of LA that would be willing to attend my birth if I wanted to have a vaginal breech birth at the hospital. And what I felt in that moment was I had had a great pregnancy. I was healthy. My baby was healthy. But all of a sudden, I felt like something was just very, very wrong. that something was wrong with me, something was wrong with baby. Worry started to seep in. And I was just so incredibly blessed to have you, to have my midwife and my doula, Ivy, who you know,
Yes,
who
very
kept
well.
telling me that this is not something wrong. It's just a different normal and that there are things that we can do. But I realized that going from having planned a home birth, I just started to see that I might be just forced to have a C-section. And there were so many thoughts moving around my head, and none of them were positive in the beginning. So luckily, what I found out was that my backup doctor, Dr. Crane, was one of those 3 doctors in all of LA. I actually think one of them was going through retirement at that time, so there were 2 doctors. He was reluctant, but he said that because I was a second-time mom, I was tall, my pelvis looked good, he was willing to deliver my baby if he stayed breech vaginally, not through C-section. So I want to like dig into that because I know that there are a lot of mothers that go through a similar thing. And from what I understand, that up to the year 2000, there were 2 options for breech babies. You could have a vaginal breech birth or a C-section. And then in 2001, something changed. And basically vaginal breech birth, that option was almost entirely gone because of one study.
Mm-hmm.
Can you tell us about that? What happened?
Well, if we back up a little bit,
Sure.
you go back just over 100 years, and cesarean wasn't really all that safe, medically speaking. Even just a little earlier than that, oftentimes it was very unsafe, and we only did them under the most dire circumstances if we had no other way to save the baby or save the mother or save them both. As the techniques got better, we started to really perfect cesarean birth from a medical standpoint, and the success rates became very high and the complication rates went down a lot. We started to apply the test, who's going to benefit more from a cesarean birth than from a vaginal birth. And there are certain things like, for example, placenta previa. If the placenta is sitting right on top of the cervix and the baby would sort of have to smash through that placenta to come through, that's something that I think pretty much everyone agrees that you're better off having a cesarean than a vaginal birth. So we just started to apply all these different scenarios and seeing, when would we be better off, the mother and or the baby be better off having a cesarean versus vaginal birth. So the study that we're talking about sort of applied that question to breech babies. There are certain complications that can occur during the vaginal delivery of a breech baby that don't happen with a vaginal delivery of a head-down baby, and that don't happen with the cesarean delivery of a breech baby. And so medicine wondered, would babies in a breech presentation be better off being born by cesarean than being born vaginally to eliminate those 2 potential risks from happening. And the risks are really, one is called umbilical cord prolapse, where the first thing that comes from the uterus through the cervix into the birth canal is the umbilical cord. And that can be a dangerous complication because the next thing that comes through is the baby. And if the baby compresses the cord, but the cord gets kind of compressed between mom and baby, then that cuts off the baby's supply of everything necessary for life, oxygen and blood. So that's a serious complication, or potentially serious complication. The other one is, what if the whole baby comes through, right, legs and butt and body, but then the head gets stuck. So you have head entrapment and the head's stuck up inside mom and the baby's trying to breathe. That can also become a serious complication. So we thought, what if we can avoid those by just doing cesarean birth with everybody who has a breech baby? And so this term breech trial, to simplify it, essentially took 2,000 women who had breech babies. They were not head down close to birth, 37 weeks and beyond. That's term is considered 37 weeks. And, half of them were to deliver vaginally and half by cesarean. And to check the immediate outcome, how healthy are the babies after each different type of birth. And the study's conclusion, I believe, said that babies who are breech born vaginally did better, small but statistically significant better outcomes than babies who were breech and born vaginally. So based on that study, the United States and Canada, like pretty much immediately, made the recommendation that all breech babies be born by planned cesarean, typically at 39 weeks. And we really stopped teaching doctors in training how to do vaginal breech delivery. It's an art form that's a little bit different than delivering babies either by cesarean or head down vaginally. And so some of those skills ever since then have been lost, and you really only have old timers who've been doing it for a long time now,
Right.
who are trained that way, and who pretty much, like your doctor, he said when he was a resident, and he's still practicing today, he's still kind of popular and busy. He said when he was a resident, they did them all the time. They never thought, oh, this one's breech or this one's head down. They just caught it whichever way it came out. Mm-hmm. And so he still has the knowledge, the training, and the skill that is hard to get nowadays. He prefers, and one thing that was lucky for you is that you already had a vaginal birth, uncomplicated. So they would say you have a proven pelvis, so to speak, that a baby can come through and not get stuck. And that obviously significantly decreases one of the two risk factors of a baby getting stuck. Mm-hmm. The other one, the cord prolapse, they try to mitigate that by selecting which types of breech they deliver vaginally. Just like when a baby's head down, the head typically covers the cord, so the cervix, so the cord can't come through first. When they're butt down, the butt typically covers the cervix, so the cord can't come through first. Right. So a lot of doctors who will deliver breech, the ones who are left that will deliver breech, won't do it if the foot is down and it doesn't fully block the cervix. So you might have that cord problem. They won't do it if the baby is like floating, nothing's really down there or transverse. So there's nothing to block the cord come through. Every doctor I know who does, and there are some midwives who still do it also, just not in California anymore. Every practitioner who I know that's proficient in breech birth has criteria, several criteria that they do, and they do selective vaginal breech delivery. Obviously, they don't want to do it if there's risk that's, outside the bounds of normal obstetric risks that we take all the time. And so, they do selective breech delivery, and for some of them, their selection means you already had a vaginal birth, but others don't require that as long as you meet the other criteria.
Right. So what I'm wondering, because I remember when I talked to my doctor, Dr. Crane, who was willing, because I was a good candidate, but he was still reluctant, and this whole issue of liability. And then, as you said, there are only a few doctors that are even trained in this now. Here's my first question. Doctors today, are they even trained in vaginal breech births? Like, could they do it if they had to? Or what is the situation there? Because in my situation back then, almost 3 years ago, it sounded like there were only very few doctors that even could. Right.
So unfortunately, it's almost impossible to get the training now because there are so few vaginal breech deliveries happening, at least in the United States and Canada, that a resident would never get enough experience with breech delivery to feel comfortable, confident, and competent to do it. It's very hard for them to get that experience, even if they could go on simulators and learn how the different presentations of breech come down, the different complications with breech and how to remedy them, to actually see them done in person to get enough experience during training is very, very difficult. Both the United States and Canada, subsequently after that 2001 term breech trial recommendation that all breech babies be born by planned cesarean, eventually in 2006 and 2009, the US and Canada respectively sort of changed their recommendations to open the idea for vaginal breech delivery maybe not being so crazy anymore and being a potentially decent option for some people. But at least in the United States recommendation as of today, it still says if you can find a skilled provider. And that's the real problem. It's very hard to find skilled providers.
And I remember you saying that to me because I made a note of it. I actually wrote it down and I've saved it all these years, that you said that, we have doctors who are allowed to attend vaginal breech births, but they don't want to, or they don't have the training, they don't have the experience. And then on the other hand, you have midwives who who are trained and they would love to attend these births, but they are legally not allowed to. Would you say, I mean, I might have quoted you completely wrong, but that's what I remember. Are midwives somehow more trained in it? Do they have more experience with it? I mean, I only really know the laws in California. Are there states in the US where midwives are legally allowed to deliver a
Yeah.
baby?
And they used to be allowed to in California too. It's not been that many years since the laws changed here. The scope of practice changed. And that's kind of a whole nother discussion on why they changed. But, and it's, you know, it's arguable about what's the best thing for a mother and a baby. And sometimes the arguments can be made on both sides. And what pains me is that we can't even present these arguments to someone who's pregnant with a breech baby because most of the choices aren't even there. So a lot of times, even when the choice is there, it'll be presented, and one expectant person will say, I'm going to try for this vaginal breech delivery. Another person will say, I love that I have the option, but I'm going to go for the cesarean breech delivery. And there's no wrong answer. It's whatever choice you want to make. You know, if you're able to get the information, what are the pros and cons, risks and benefits of each of my choices, and then I get to make the choice. That's, in my mind, that's how it should work. It's informed consent or refusal. And again, none of these, there is risk with every option that you take. I would never say there's no risk. But it's important for us to kind of, to the best of our ability, the best of the data that we have, to spell out what the true risks are, and for you to decide which ones you want to take and which ones you don't want to take. We do that all the time with every birth, really. There's always going to be some risk. There's no guarantee that a birth ends perfectly.
Yeah.
So, you know, and then there's people who've done it, and people who had great experience with it recommend that everybody do it. It's the coolest thing ever. And it's, you know, it's just a birth. And then there's other people who've done it and have had complications and recommend that nobody do it, because if they can go back and turn back time, they wouldn't do it. It's not, again, those, I don't think those experiences, one way or the other, should limit somebody else's choices when really these risks are within the realm of normal obstetric risks that are taken on a regular basis. So the other thing that you said about Dr. Crane, for example, and liability, is that, you know, the real issue with most doctors is they don't have the experience and training and even the tools. There are special tools for breech. And it's just not in their comfort zone. You know, they're not being bad people. They just don't have the skills and the expertise and the comfort to be able to do it in a way that they feel is safe for you because of their lack of experience and training. And the ones who do have the experience and training, like Dr. Crane, oftentimes worry that now that it's no longer the community norm, most people who have breech babies still schedule cesarean around 39 weeks. Vaginal breech delivery is not the community norm, even though it's within the realm of recommendations from ACOG. If anything were to go wrong, whether it has something to do with the breech or not, whether there was negligence involved or not, their liability is going to get them. You know, it's really easy for a prosecutor to come in and say, you did this, even though it's not the community norm. You could have just done a cesarean birth, and had you done that, everything would be okay right now. Even if that's not quite scientifically true. You know,
Right.
it wins hearts and minds. Nobody wants to see an injured mother and injured baby.
Of course. Yeah.
And then, you know, you see the same thing on the other side when things go wrong during a cesarean sometimes. But it's a lot easier to defend yourself to say, well, this baby was breech and the community norm is to do a cesarean, and this unfortunate thing that happened is just a consequence that sometimes happens when we do cesarean. It can't be completely avoided. So from a liability perspective, which is the risk to your provider, vaginal breech delivery is very risky for them, and cesarean birth is pretty safe for them. The medical risk and the liability risk don't always go up and down together. So just because it's more risky for your provider doesn't mean it's significantly more risky for you.
Right.
but because it's very risky for them, they won't want to offer that option. And
Sure.
I'm not blaming them either. I mean, it's a
No, it
real
makes
serious
sense.
pickle.
So, what could be the benefits of choosing a vaginal breech birth instead of a C-section? Just in case somebody's watching here right now and wondering, why would I go with vaginal breech birth if I could instead of doing a C-section? Of course, that's a very personal choice, but just some thoughts on that, why that might be better for some people.
Yeah, so for one thing, a lot of it boils down to feeling.
Mm,
There are some women who would rather have a cesarean birth anyway, even if the baby is head down.
right.
So for them, having a cesarean birth for breech is not a big deal. This is something that I encounter every day at the office, often several times a day. And so I've seen thousands probably of women who are concerned about a breech baby, 33 weeks and beyond, and the baby's breech. Oftentimes they're planning for years, and certainly for the months of pregnancy, a specific birth, how they see it going. Is sometimes for women how they dream of their wedding and how they want their wedding to be. They dream of their birth and how they want their birth to be, and they prepare for it in all sorts of different ways, the mind, the body, and they want unmedicated, uninterventional birth. They want to really feel everything and be super present for everything, and they want to just do it together with the baby. Sometimes they're thinking about health benefits for the baby, things that happen to the baby when they move through the birth canal that don't necessarily happen with a cesarean birth, exposure to the microbiome, and other things like that, being squeezed, the brain center and lung centers through the pelvis. There's also, it is kind of an intense surgery. I hear lots of different feedback from people who've had cesarean. Some people feel like it's not nearly as intense as they thought it was going to be, and the recovery was a lot easier than they thought it was going to be. And a lot of people feel the other way around, like they never fully recover from it sometimes, that it's a pretty major surgery that disrupts their homeostasis, and it cuts into the abdomen, it cuts into the uterus, and it's kind of an intense surgery, even though we've pretty much got it down to a science. For other women, this was interesting in a documentary that I worked on about vaginal birth after cesarean. We interviewed a bunch of women who had cesarean birth with their first baby, unexpected cesarean birth with their first baby. So they planned on a vaginal birth but ended up having cesarean. And then with their second baby, they just elected for a repeat cesarean. Mm-hmm. And every single one of those women, it's not a very big pool, so certainly not everybody feels this way, but every single one of those women kind of used the same terminology and almost said the same thing verbatim about how in the birth with no labor, just a cesarean with no labor, something was missing for them. It felt surreal was a word that came up oftentimes, had a hard time bonding with their baby. It just didn't feel connected. And they all use that terminology. It's sort of interesting because women who just had an elective C-section the first time didn't seem to miss that. But women who had labor and then a cesarean and then chose to have a cesarean with no labor, they all missed that some kind of transition, whether it's hormonal, neurological, emotional, some sort of transition from being pregnant to not being pregnant, rather than just, lying down on the table and having the baby taken out right away. So I think there are a lot of benefits. And then the other medical benefit is that if you're planning to have more kids, every time you do a cesarean, the next pregnancy and birth, whether it's cesarean or vaginal, becomes a bit more risky because of each cesarean that you've already done. So there's a distinction. Somebody who's not planning to have any more kids may not care as much as somebody who's hoping to have 2 or 3 more kids.
Right. Wow, that's very, very interesting. So how do we bring back, and I love calling it the art of vaginal breech birth. How can we, now the doctors aren't trained in it and they don't have the experience. So what can be done for mamas to have at least these options? And I love what you said, that It's not for everyone. Vaginal breech birth may not be for everyone, but informed choice is. So to have the options, because this incredible documentary that you told me to watch, Heads Up, is so great and talks about all of this. And many of the mamas there say that they were just devastated because they felt like they had no choice.
Right.
How do we bring back choice?
So one thing I think is important is if we're doing true informed consent. So if you're a provider that doesn't offer vaginal breech delivery, but there are other providers in town who do, it seems to me that the true scope of informed consent is not to say that your only option is to do a cesarean at 39 weeks or 40 weeks, but that there are other providers in town that offer vaginal breech delivery. Even if you don't recommend it, you could caveat that by saying, but I don't recommend it for X, Y, or Z reason. But a full scope of informed consent means we tell our patients what the choices are. Mm-hmm. If you go to a general physician and they see you and they treat you and they keep you healthy, but then all of a sudden there's something comes up that's outside their scope that they're not experts in, like a liver thing or a heart thing, then they send you to a specialist. And at this point, the way I see it is that there are doctors in town who are very experienced and comfortable with breech birth, and they're the specialists. So as a general OB/GYN, if a specialty like that comes up, it would be important for them to at least mention that there are other options, even if they don't offer those options themselves, and even if they don't think those options are a great idea, because ultimately it's not really their choice.
Right.
It's kind of interesting. Since 3 years ago, when you almost had this problem, mm-hmm. The doctor who had, I think he was in his 80s, he had done 500 vaginal breech deliveries and almost 20,000 births altogether. He was delivering grandbabies of babies that he delivered.
Oh my gosh, how cool is that?
On the one hand, it's like super cool, but I'm almost getting to the point where my patients are old enough to start having babies, patients who I delivered, right? Babies who I was part of their birth. And that already is making me feel super old. I can't imagine
super old.
like when their kids start having babies. That's crazy.
Yeah, but still really cool.
Yes, super cool. It blew my mind when he told me that.
Wow.
Yeah, and so he did retire, which was sort of devastating because you lost the art. Nobody around him, none of the doctors who were with him for years and years, were intellectually curious enough to want to learn from him and to be taught the art. He was doing enough of them that he could have taught people, and he would have been happy to teach, but there's nobody at the hospital curious enough to learn. Wow. And luckily, a few other doctors did pop up here in Los Angeles who have had the skill in the past and either just always did them, but only for their own patients. They never really advertised it, or maybe stopped doing them for a while, but then started doing them again now that there's a demand for it again. And so there are a few more options available, especially if you've had a vaginal birth. Some of the doctors, that's their criteria. If you've had the vaginal birth, they'll do a breech with you as long as you meet the other few criteria. So, the reason they popped out of the woodworks is because there's more demand. The more education there is, like what you're doing right here, right now, and getting the word out to people early enough so that if they find you, the real problem is you find out your breech usually at like 34, 35 weeks, sometimes even later, and there's no time to react to it and do homework and get information. So it's the kind of information that has to kind of get out to everybody, regardless of whether you're pregnant or not or have a breech baby or not. If you care about informed choice, you have to spread the message. And that's why we made that documentary, Heads Up, The Disappearing Art of Vaginal Breech Delivery.
Brilliant. You guys got to watch it. It's so good.
Yeah, you could see that online at headsupfilm.com. And so that was my effort at spreading information about it. And I always tell patients to, ask their doctor, are there any alternatives? Are there people in town that offer this? And the more that people ask about it and want to have the option, the more at least the the doctors who have the skill are willing to come out and say, I do this, I'll be
Mm-hmm.
happy to entertain the option, see if I feel like you're a good candidate or not.
Right.
And so we should at least be maximizing the doctors who do have the training, do have the skill, who have not retired yet.
Mm-hmm.
And my hope would be that if there's enough demand, that they could start to train. I feel like the residents today are intellectually curious. I've been invited by hospitals to screen the film at grand
Oh,
rounds
wow.
with OBs and residents and nurses, labor and delivery nurses. And I didn't know. I sort of felt like I'd get tomatoes thrown at me in that setting. But for the most part, the residents were very curious and they asked really pointed, solid questions that gave me hope. So I feel like if there was even, one hospital in each major city that became a breech designated hospital where they always had somebody on call who was comfortable during breech, or that they can call in for breech, then those centers would have enough experience for their residents to really start to learn it and get comfortable with it, and to really feel out who really is a safe candidate for breech delivery and who isn't. What are the protocols and methods of managing a labor and delivery that with a breech baby that keep it safe all the way through the end, and how to handle things that come up during a breech birth that don't come up during head down birth. So the complications happen all the time, but doctors are trained to mitigate them and to intervene and to make sure things end well. And that's true with breech too, if you have the training.
Mm. That's positive news. I'm very, very happy to hear that. And we've talked about criteria a few times. I just want to go over it. What would make you a good candidate for a vaginal breech birth?
So, I'm not an OB and I don't deliver breech babies, but each one has their own criteria that there's a lot of overlap. They're essentially looking to mitigate those two complications. Let's not set up a situation where the umbilical cord, it can easily come through the cervix first, the umbilical cord prolapse, and let's not create a situation where a baby's likely to get stuck. The head is likely to get trapped on the way out. So one thing we already talked about is pretty much all the people who deliver breech birth that I know of personally, one criteria is that the butt is down. It's not a footling, it's not transverse, it's not floating. And that's really for both. If the foot's down, so it sets up a scenario where the cord can prolapse through first. That's not great. But even if the cord doesn't come through first, the cervix only has to open, let's say, 5 centimeters for a foot to come through, 4 or 5 centimeters, right? And then the baby starts to slide down, but the cervix is not open yet enough for the head to come through. So you set up a situation where the head gets trapped in there. So by only doing butt down babies, the cervix got to open pretty much fully for the butt to come through. And that helps mitigate that problem where the baby starts to slide through before the cervix is fully open. And along those lines, each one has sort of an estimated weight, fetal weight, that they're comfortable with. If the baby seems to be getting too big, whatever that means for each one, 9 pounds, 9.5 pounds, they wouldn't do it because that increases the odds of the baby getting stuck. Some of them look at the head. They want to make sure that the head's not locked back into extension like that, because when they're rigidly locked back in extension, they're more likely to get stuck on the way out. So, each one has different things that they look at. They look at mom's pelvis to see if there's any trauma or any reason why the pelvis may not be ideal for a breech baby coming through. And I think the last thing that has been mentioned to me that they look at is, the conviction of the parents. So like, how comfortable and confident are you in doing this? How much do you want to do this? And do you fully know your options and the risks and benefits? If you're not that confident and comfortable doing it, they probably would recommend not doing it. A mom who is very nervous and tense, overly nervous and tense during birth, that doesn't tend to go well for birth in general, but especially with a breech baby.
Yeah. Okay. That's really, really helpful. So let's say, like in my case, I had a little bit of time. We knew that he was breech, and I had some time to do some homework, right? And try to get him to flip, which you played a huge part in. And the good news was that when I was on your table and you were working on my tummy, Maxwell actually flipped in Dr. Berlin's hands. Like, I remember you saying, I think your baby is turning. And then you
Mm-hmm.
just gently kind of nudged him and he just did like a flip. And then
Mm-hmm.
he stayed head down. It was such a cool moment because you do help a lot of mamas. You work on their bodies, and then the flip tends to happen later on, right?
Mm-hmm.
Not that
Yeah, I
common.
would say less than 5% of the people that we work on, their babies actually turn on the table. But I've done so many of them that there's a good number and now walking around who are like, and it's not ideal because sometimes they'll be like, you got to go see him. The baby will flip right there on the table. I'm like, no, 95% of the time, that is not what happens. And that's not the goal, even for what
Right,
happens.
right.
So, when babies get past 34 weeks and they're still not turning head down, there's typically a reason for it. Sometimes it's structural and sometimes it's functional. Examples of structural could be, let's say the cord is wrapped around them in a funny way that makes it hard for them to move around. Let's say the cord is short and the placenta is up high. So as the uterus keeps growing and the placenta keeps moving further away, the baby may have to flip and be up near the placenta because of a short cord situation. Sometimes the placenta is just in the way. So if you have a head over here and the butt over here, the legs over here, and the butt's down here. So if the placenta is right here, if my head is the placenta, and they try to move this way, the head bumps into it. And if they try to move this way, the legs bump into it. So it can be hard to move because the placenta is in the way. The fluid makes a big difference, I find anyway, that the way fluid's normally measured at the end of a pregnancy, typically measured at the end of a pregnancy, is there's a couple of ways, but most common is called the AFI, the amniotic fluid index. So on an ultrasound, they would take the belly button and make a vertical line and a horizontal line. Together, they make a quadrants, 1, 2, 3, 4 quadrants, and they look in each quadrant for the biggest pocket of fluid, add those 4 together, and that's the amniotic fluid index. It's not exactly how much fluid you have, but it's an indication of how much fluid you have. And towards the end of pregnancy, a normal range for AFI is about 8 to 24. That's a big range. But how much fluid you have also kind of influences how much room the baby has to move around. So if you're at the low end of that range, 8, 9, or 10, which is totally normal and healthy and safe, it could be harder for the baby to make a turn. They may be kind of stuck in a bathtub that's kind of low on fluid. And then on the other side, if you're 18, 19, 20, or even more, that's still normal and healthy, but maybe so much fluid that the baby has so much room to move around that there's no incentive for them to pick a space and move head down. So those babies generally have an easier time moving, and those are the ones that move spontaneously at the end of pregnancy. Sometimes in the other direction, those are the ones that surprise us, and you go in for your 38-week ultrasound, all of a sudden you have a breech baby in your hands, but they're not really stuck. They're just still moving all over the place because they have so much fluid, a generous amount of fluid to move around with. And so those are some of the structural things. Another one is the shape of the uterus could be a little bit different, somewhat geometric, why when they run out of space, they want to move head down. But if you have a different shape to the uterus, a variant shape to the uterus, it may not be a shape that's conducive to the baby wanting to go head down. They may either want to go head up or get stuck. There's a heart-shaped uterus is one of the variations. So instead of being like that, you get this little septum that comes down over here. And when that happens, sometimes the head gets stuck up in one pocket, the butt gets stuck at the bottom, and the feet get stuck in the other pocket. And so it's hard for them to move around. So variant shape of the uterus is another situation. Sometimes there's functional influence. So if you're very stiff and tight and rigid down in your low back and your hips and your pelvis, when they run out of space, they may not want to go head down because it's so stiff and tight there, or they may not be able to. When they're trying to move, instead of your body expanding and contracting and helping those movements, your body may just be rigid and resisting those movements. And so where chiropractors come in is we don't turn breech babies, we don't manually move them around. But what we can do is influence the environment a little bit by working on the pregnant person's body and making sure that the low back muscles, hip muscles, piriformis, hip flexors, they're not too stiff, tight, and rigid, and that the joints move really well. And so that's what we're doing. But in my office, I find that when you invert, when you tilt the table back, if your baby's not all that stuck, once we start stretching those round ligaments and once we start releasing tight hip flexors, that gravity will just help the baby move around. And once you feel that starting to happen, if you keep moving the table or stretching the ligaments into different tilts and positions, then the baby can just literally flip on its own painlessly to the ideal head down vertex position.
And that's what happened to me and Maxwell.
That's what happened to you guys, and I couldn't be happier. It couldn't happen to a nicer person.
Oh, it was so amazing, and I just believe that your help was everything to us. But we also did a lot of other things. I just want to talk about that real quick. Actually, before that, we did speak about ECV, external cephalic version. Am I saying that right?
Yes, absolutely.
What is that real quick? Because that is something that can also be done in an attempt to flip a breech baby.
Yeah, so that's more medical. It's typically done at either 37 or 39 weeks and usually done in a hospital setting.
Right.
What happens is you go into, let's say, labor and delivery. Oftentimes it's done with a medicine called terbutaline, which relaxes the muscular wall of the uterus. Sometimes now I see them offering an epidural with it as well. And essentially, the provider will come in with ultrasound and listen to the baby, monitor the baby, and see the exact position of the baby. And then they'll kind of apply some kind of lubricant to the belly, and they'll try manually to, let's say it's a butt-down baby, they'll try to push the butt up out of the pelvis where it's stuck, and at the same time manipulate the head around so that the baby verts or turns head down. So external meaning it's done over your belly, not inside your body. Cephalic means the head is the cephalid version. We're trying to turn it over so that it's not head up but head down. And, that is sort of like the elephant and the blind man. And where, they send out the blind men to see what an elephant feels like, and they each come back with a different report. One says it's smooth and floppy, one says it's hard and shiny, one says it's very rough, but they were just feeling different parts of the elephant, right? So the ECV is very much like that. If you have somebody on her second baby and she's tall, and she has a lot of amniotic fluid, and the baby's not really wedged in the pelvis, and the placenta's not in the way, they'll sometimes go in, the whole thing takes 25 seconds and is relatively painless. Other people, especially, let's say it's a first baby, you're not that tall, the baby's on the bigger side, it's been wedged down in the pelvis the entire time, fluids medium to low. That could be a situation where it's a lot of effort, a lot of intensity, a lot of pressure, not just physically uncomfortable, but also emotionally uncomfortable for a lot of people because it's your baby and your tiger mother instinct kicks in and says, get off my baby. And so it could be a really uncomfortable experience. And it's one of those things where there's no right or wrong, but you can't just say to somebody who's had it, hey, how is the version? Should I do it? Because the factors alone could be very different between you and them. And even with the same exact factors, it could just be different, very different experience from person to person. So the success rates on first time mom with a breech baby is somewhere around 40%. It goes up if it's not your first baby, and again, it goes up if your fluid's on the higher side, the baby's on the smaller side, you have a little more room, stuff like that.
Each case is so different.
Absolutely.
So what if you're early on enough, like I was? We caught it pretty early, and you are just willing to do whatever it takes to get this baby to flip. What are some things that mamas can do? Both in treatments and also the kind of like do-it-yourself homework in your home. What are some things that mamas can do?
So in terms of do-it-yourself at home, some of the things that are often recommended are doing positional exercise on your own, getting into a situation where your hips are higher than your shoulders, so gravity can help move out the part that's in your pelvis, the presenting part that's up against your cervix, that is not ideal, right? We like a foot or butt, help that slide out so that the rotation can take place. Also, when you get in those positions, it tends to help stretch out some of the musculature in the round ligaments so that they loosen up a little bit on their own. There's a website called Spinning Babies that has a lot of those exercises, a video and pictures of the exercises. So it gives you a lot of different options and shows you how to do them safely. Other things that people sometimes do are get into a pool and either just move around in the pool or try to do some flips in the pools so that the baby has more buoyancy. Did you do that?
I did.
Oh, yeah, it doesn't surprise me. I know you would have done just about anything to.
I did everything.
To give them a chance to get down there. And so, there's not protocols on a lot of these things, but there are anecdotal stories where people say, I did that and it worked for me. Things that you could do in terms of somebody doing something with you, to you, or for you. So the chiropractic that we do is to open up the joints, especially around the pelvis. The massage work that we do is to loosen up soft tissues like muscles, ligaments, and tendons, especially in the low back, hips, and pelvis, and just to loosen them up. Sometimes when the baby's stuck around a rib cage, we'll do massage over there to loosen that up, try to create a flight path for the baby to spontaneously move. We do Chinese medicine, a mixture of acupuncture and moxibustion, which is stimulating those points instead of with needles, but with heat coming from an herbal stick that burns. And the herb is mugwort, which is a little bit of a relaxant. And you see it all the time. Once you're burning moxa for 15 or 20 minutes, those babies start to jump around like crazy. So it creates more spontaneous movement. So if I can create more functional space with the body work and we can create more natural movement with the Chinese medicine, that's very synergistic. That's how seemingly a lot of the babies move on their own.
Did that too. Was burning that moxa every night.
And then other people do reflexology, homeopathic. There's hypnosis techniques for bridge babies. Those are pretty much, and then there's like rebozo, where I don't know if you did that one, where they take a shawl, it's like a Mexican scarf, and they kind of do some sifting to help create movement for the baby. A lot of the doulas are trained in that, and they do that.
I heard about that. I never did it though.
Yeah, those are pretty much the things I know that people try in terms of modalities.
What about craniosacral therapy?
So craniosacral therapy, most people don't know what it is. It's kind of a technique. It's a modality that's part structural and part energetic. And the bottom line on it is that it causes, when it works well, it causes a deep relaxation of the central nervous system, the brain and spinal cord. And the body just becomes very, very relaxed. And so when my body work modalities are focused on muscles, ligaments, and tendons localized to the low back, hips, and pelvis around the baby. But craniosacral, when it's successful, just gets the entire body to turn into a wet noodle. And so, again, that kind of relaxation to be able to totally let go. There is some thought, it's hard to say to what extent or even if it's accurate, but there's some thought that stress and tension, emotional stress and tension that you hold on to can cause breech positioning as well. So when you do things like meditation, hypnosis, and craniosacral therapy and release that tension, so that may be helpful as well.
Yeah, that's great. And I also, just for the do-it-yourself stuff, one thing that Davey, my midwife, told me about, it's just like meditate and communicate with your baby, which not all mamas might believe in, but I certainly did. And it was a very sweet experience and exercise to do. The inversions, like you mentioned, and then cat cows. I did that for 5 minutes, 3 times a day. The yoga position or exercise, and then walking. It's worth trying. I walked plenty, and that's just really good to prepare for birth in general. And then, like you said, floating and swimming. That was sort of my little list that I have here.
That's a nice list.
It's a nice list. So there are definitely things that one can do to try to get the baby to flip. And like you said, you mentioned spinningbabies.com is a great website. And then your own website, informedpregnancy.com, which has so many resources for all sorts of things. And your documentary Heads Up, which I just did so much for me. And then again, I just want to end with saying that, Maxwell flipped, but I feel like that experience was so important for me because I had to let go of so many plans and so many fixed ideas that I had, and just knowing that he was breech and that I just had to surrender to whatever was about to happen. It was such an important experience for me because we did go ahead with our home birth when he flipped, but then his heart rate, I can't even remember exactly what happened, but his heart rate lowered for long enough that Davy said that she wanted us to leave home and go to the hospital, to transfer to the hospital. Everything was fine. But because of the experience that I had, I was able to just mourn my home birth for like a minute, and then it was back to business. And we just went to the hospital, and I was open to whatever had to happen, however he wanted to come out, because I had that practice and experience earlier. So we never know what's going to happen.
You never know. I would
Surrender
say,
is so important.
yeah, just a few final thoughts are just that, in my mind, a birth plan is a flowchart. And page 1 of the flowchart is the most natural birth that you as an individual could see yourself wanting to try to have. For some people, that's alone in a strawberry field. For some people, that's at home with a midwife or at home with a doctor. Other people, it's at a hospital with a midwife or at a hospital with a doctor. For some people, it's vaginal. For some people, it's cesarean. For some people, it's medicated. For some people, it's unmedicated. There's a lot of ways to have a baby in today's day and age, and there's no wrong way. But page 1 of your birth plan should be the most natural way you yourself could see yourself wanting to have the baby, and aiming for that, and setting yourself up with a provider who supports that, or setting yourself up in a scenario, a setting that supports that and is conducive for that. But it's a flowchart. If something comes up like a breech baby or a placenta previa or anything else that comes up, or a baby's heart rate drops during labor, that's what makes home birth safe, is when you have a savvy midwife who says, this is a pink flag. I don't want to stay home and see if it turns into a red flag or a white flag. This is when we transport to be safe. And then in your case, everything went well. And you were just at the hospital to be safe. But that's part of the flow chart. It's part of your plan. Your plan didn't fail. You followed your plan all the way through. And so once the journey starts, it's really, you're aiming for that spot, but it's not like steering a precision vehicle. It's almost more like steering a hot air balloon. If there's a gust of wind going this way, you're going to take a different path, but you're going to get to the same point, which is having, the origin is a healthy person with a healthy baby inside their body, and the destination is that same healthy person with a healthy baby outside their body. Along those lines, as much as I advocate for people to have the choice to do vaginal birth, even if the baby's breech, or vaginal birth, even if they've already had a cesarean, I also advocate for people to have a cesarean birth, where sometimes that's being deprived. They're being deprived of that choice. Along those lines, we have a podcast called the Informed Pregnancy Podcast, a whole bunch of episodes about breech, breech stories, and experts talking about breech. But we also have an episode called The Gentle Cesarean, where, somebody who is very intent on having a vaginal birth or an unmedicated birth, who is now facing a cesarean birth for any reason, but breech is a common one, can kind of sit and listen to it and try to figure out how to retool their birth plan so that they have the most magical birth experience that they can with a cesarean birth. And it is a magical moment when a baby comes through your body into the universe, whether they come an inch higher or an inch lower. And you can do things, or choices you can make in a cesarean birth that can make it the experience that you want to have. It does not have to get lost because it's a surgical birth and not a vaginal birth. So we tried to compile all of the movie, Heads Up, and some of these podcasts and some stories, articles, and we made a separate URL for it called breechpodcast.com, where we keep adding to it. And we also have a list of providers around the country. It's not the biggest list in the world, but of providers that we know that are known to do vaginal breech delivery if you meet the safety criteria.
You are amazing.
Oh, thanks.
Thank
I'm
you for
trying.
saying all of that. No, you're doing it. You're doing it. And you have been doing it for so long. We are so lucky to have you. And I love everything that you just said, and that there truly is no birth that is right or wrong. And what's important is that you know what you want, and that you can make informed decisions, that you know your choices. We so appreciate the time and that you talked to us about this. It's so important. So guys, remember informedpregnancy.com. Check out Heads Up. There is so much to learn about this, and that's what's truly important. Thank you again so much for your time, Dr.
Thank you,
Brilliant.
Emily. I appreciate you.
I love and miss you.
Bye-bye.
Bye.